I was thrilled to have the opportunity to speak to everyone here. And it's coming on the heels of, and I'm just gonna share my screen, of our interest in trying to move our collaborations with various European groups forward, both from a GNAO1 perspective, but as well as in the pediatric DBS world. Can you see my slide?
Yes.
Okay. Okay. So I originally developed this talk for neurology grand rounds here at Washington University. And I developed the talk to be kind of the type of talk that I would have wanted to hear as a trainee or young faculty member. And basically of how do you get from the patient that you see in front of you in clinic to studying and understanding the disease so that you can better help that patient in clinic. And so being that we're a rare disease community, the way that we have to go about doing our research is oftentimes different than, say, diseases such as stroke or heart disease. And so I think it's very important that we have these types of networks where we can share our experiences and our successes and our failures such that we're not constantly reinventing the wheel. So I really want people to be able to understand why natural history studies are important and how do you go about doing them in these diseases. And so I'm going to do this by taking you through the process of from the initial case that I saw of this disorder to developing a clinical research program. And along the way, I hope that you learn the clinical features of GNAO1 disease as far as we know them to now, the different types of natural history studies and when they should be used, and then give you some examples from other rare diseases that we use to build our studies and some early results from the first 2 years. So, and I apologize for those of you that have heard me speak before, some of this is going to be a little redundant, but I want to show you the first case. So this little girl's name is Lara, and I have the permission of the family to use, and they've asked me to use her name. And she had an unremarkable pregnancy and delivery, but they noticed fairly early on that something wasn't right, and she was diagnosed as being hypotonic at about 6 months of age. She had a very extensive diagnostic workup, which all was unrevealing. And then she began having chorea around the age of 4. And this was stable until about age 8 when it became intractable. And you can see here, people didn't know what to make of this. And so she's in the epilepsy monitoring unit, and these were not seizures. So these spells of movement eventually became constant. And she spent most of the last 18 months of her life in the ICU. She was trach and G-tube dependent and ended up dying of a presumed sepsis secondary to a pneumonia from the trach. And, shortly before she died, her whole exome sequencing came back as a variant of unknown significance in this, newly described gene. But they said that it was not thought to be pathologic because she didn't have epilepsy. And all of the previous cases had been described as having early infantile epileptic encephalopathy. And so I went to look at the case or the paper that was published, and buried kind of in the supplementary data was this video. And it was kind of put on as an afterthought by the authors saying, hey, 2 of the cases had some weird movements. And so I looked at this video and I saw these movements and I thought that they looked remarkably similar to the movements in my patient. And I thought that this cannot be a coincidence. And while I was confident that my patient did not have epilepsy, I contradicted with great trepidation the genetics team and told the family that I thought that this is what her disease was. And so I kind of want to start out by just having a quick question. And, you know, I've kind of mentioned a few terms describing the movements, but going back to those movements, how would you initially have characterized those movements?
Okay, already half of the participants have responded, but we will wait for 10 more seconds. Okay, so here are the results.
Okay, well, so I agree. I think that that is Chorea embolismus, but they're like most pediatric movement disorders. There's a mixed quality to them. So there is some dystonia in there. I would say that there's less likely to be myoclonus, but you know, many of these kids were formally diagnosed as having athetoid CP, and partly because nobody knew what else to call them. But as we've kind of come to know in this disorder, you know, which is sometimes called GNAO1 neurodevelopmental disorder, sometimes just GNAO1 disease, the hallmark features appear to be hypotonia, especially when they are little. This is almost always present, as I'll show you later. Some sort of global developmental delay, however, in many, if not most of these children, intellect seems to be preserved. And then there is either an early infantile epileptic encephalopathy or a movement disorder with these episodes of Chorea embolismus, or both. Now, this was kind of the early description that I used when giving these presentations. And as you'll see, our understanding of these features has changed somewhat and has evolved. But really, what is the hallmark feature of this disorder that makes it somewhat unique and somewhat recognizable if you've seen it before are these Chorea or hyperkinetic storms. And I say or hyperkinetic because there is some dystonia in this, and in the literature that there have been descriptions of these storms as being status dystonicus. But really it's these very high amplitude, distressing, ballistic, you know, flinging motions of the arms and the legs and the trunk. And that can be so severe that it leads to rhabdomyolysis, ICU stays. And then there appears to be a component of autonomic instability that is unrelated to the movements. And the basic science behind this is still emerging. And there was just a paper that came out a couple days ago that should help expand this understanding. But in general, the GNAO1 encodes the alpha subunit of a G protein. And this leads to abnormal regulation of cyclic AMP signaling. And in general, and this is a very broad generalization that is still being worked out, the loss of function of that protein may lead to epilepsy, and the gain of the function may lead to Chorea. And this may explain some of the different phenotypes that we see. So I've told you about what is GNAO1, and now I want to share a little bit of who is GNAO1.
What is GNAO1? GNAO1 is a protein coding gene. Most people with a GNAO1 neurodevelopmental disorder are diagnosed as infants or young children. The GNAO1 diagnosis is made through genetic testing, and the first children with a GNAO1 disorder were only identified in 2013. Some people with GNAO1 disorder experience seizures, some have abnormal movements, and some have both. Nearly all have developmental delays beginning in infancy. Many people with GNAO1 disorder use wheelchairs and communication devices. Some can walk and talk. Scientists suggest that GNAO1 disorder could become one of the most common rare diseases around the world as the cost for diagnostic tests is reduced and more patients are tested. There is no known treatment or cure for the GNAO1 disorder. So, who is GNAO1?
Annabelle is a sweet, beautiful, happy 4-year-old with a caring heart and the most beautiful smile. She is patient and so loving with her brothers and always wants to help and take care of them. She is a lover of chicken tenders and french fries with extra sauce and a princess-obsessed little girl. She loves a good book and will spend hours reading. The GNAO1 mutation has limited Annabelle's ability to walk and talk, and it causes her to not have full control of her body movement sometimes. She uses a wheelchair or crawls to get where she needs to go, and she uses an AAC device to talk and communicate with us. Knowing there is no cure for the GNAO1 mutation is heartbreaking. We are praying and working hard to change that.
Hi, my name is Anna Joel, and I have a genetic condition called GNAO1. So it's been hard for me in the past to talk about it, because obviously I did not know what it was. 17 years of my life, I had no idea what it was. I always knew I was different. Like when I was little, I was like 2. I was walking like the way I walked, and this guy came up and told my mom, "Hey, is your kid drunk?" Like I was walking and my mom like she laughed it off. Like when she told me like later, like when I was older, like I was so mad. I like to play ultimate frisbee. I play for the school's club team, and it's an all-girls team. So like a lot of my friends, I met all of them through frisbee, which is like they're really awesome. I plans for the future. I want to go to college. I want to study something in biology. I definitely have the motivation to like pursue genetics and like maybe help the other kids who have my rare genetic disorder.
Okay, so I wanted to show that to kind of put a face and a voice to this disorder and go into, and obviously that video shows you that there's a much broader phenotypic spectrum of this disorder than was first described, which I think is going to be a theme throughout this presentation, and many of you will probably recognize that as we're beginning to learn more and more about different rare diseases. So one of the big parts that I think is really important for researchers who are doing research on rare diseases is to work with the family groups, and that they need to be not just a sideshow or somebody who's raising money for you, but that they actually need to be part of the team. And so the Bow Foundation, around the same time that I saw my first patient and the first people were being diagnosed, the first inklings of the Bow Foundation came about when several families who were interested in starting a foundation kind of came together to pool their efforts. And they, like many of these foundations, want to have many areas of focus, but primarily research, family support, and awareness. And so they have been the catalyst for much of the research that has been going on. And they set up a meeting that was a side symposium at Society for Neuroscience in November of 2017. And it was unlike any meeting I had ever been to. It was a combination of researchers getting together to do research presentations like we would normally do, but then also family groups were there. And the meeting was live streamed over Facebook to people all over the world. And so when I was done giving my presentation, I was answering questions from people in South America and in Europe. And then the researchers sat down with the family groups, and we kind of posed the question, should we do this again next year? And almost everybody said, yes, we should do this next year. And I said, well, if we're going to do this, bring everybody together, then we should start collecting data. And so that's how we launched the natural history study. And so in April of 2019, we had our first annual joint family and scientific conference plus the natural history study in St. Louis. And the plan was to have the second annual in 2020. And as everyone can understand, that didn't happen. And so we transitioned to a virtual symposium. And then my team converted the natural history study to a virtual collection of data in those patients who were not already my patient. And this had many unexpected pluses and minuses to it. But the biggest boon was that we were able to expand the study to include many more international families, as well as families that could not travel either for financial reasons or for disability reasons. So the next couple slides are going to be a little bit on the wordy side, but I've taken this, the wording directly from a very good document that was published by the FDA, which is the governmental organization in the US that monitors food and drugs and medical devices. And they put out a document trying to promote the use of natural history studies in rare diseases. And I don't need to tell you guys many of these points, but that their point was that we need to promote the fact that this is a serious unmet public health need. And if we pool all the rare diseases together, they're actually very common. So the 4 goals of a good natural history study should be to characterize the population. And this information is useful to provide information for future intervention trials about who you should include in the study. Should you include people with, unknown variants? Should you include pre-symptomatic patients? When should you treat? How long do you need to do the trial for to get significant results? And also to determine specific endpoints. And so the second goal should be identification or development of clinical outcome assessments. And this is what I'm going to talk a little bit more about with our natural history study. And they gave some examples of what could be used as a clinical outcome assessment. You could do a clinician reported outcome, and such as a movement rating scale that I'm going to talk a little bit more later. You could do an observer reported outcome, such as the CP child, where the parents or the caregivers fill out surveys. Or you could do something like a performance outcome, where you measure certain things. And in our case, we use the gross motor functional measure, which is has a very wide range of ability levels that it can measure. And for fine motor, we initially chose the Peabody assessment. And I just want to read this next part. It says, a natural history study can help evaluate the ability of a new or existing clinical outcome assessment to detect change in a particular disease or a pattern of progression in a disease or symptoms of the disease. And they can also be used to evaluate the performance and reproducibility of these measures. The third goal should be the identification or development of biomarkers. So this would be a much more objective measure, something that such as an MRI or a blood test. And these are much harder to find and develop, but they are usually more reproducible and viewed more favorably for clinical trials. But the biggest reason to do a natural history study for rare diseases is that the data and information could be used as a external control group, such that when you do go to, say, a drug is developed or a treatment regimen is developed, the size of the placebo group can be much, much smaller if you have a good natural history study. So what are the different types of natural history studies? So I like to think of it in these enclosed circles because I think they build on each other. So, you know, a retrospective study is, you know, where you just kind of gather records. So the patient doesn't necessarily need to be there. Or you can do a good literature review. The benefits of this is that it's the cheapest, you know, and it can fill critical knowledge gap by pooling lots of data. The cons is that, you know, the information is not gathered in a systematic way. And so it can be very variable or missing or inaccurate. So a cross-sectional study is where a single study actually examines patients across the spectrum of the disease at one specific time point. Okay, so that's theoretically, you're examining different stages of the disease, but in different patients. And it's, again, it's quick to conduct. The downsides is that you can't really develop a cause and effect relationship. And something that caused a complication in a patient who's 17 now might not cause the same complication because medical science changes. And then the gold standard is considered a prospective or longitudinal study. And this is where you collect data from patients over time in a systematic fashion. And it can really help you understand how the disease develops. And this is really the only one where you could really use it as an external control group. The cons is that it's very expensive and requires a long time and a lot of investment, both from the researchers and from the families. So let's look at some other rare diseases that we could potentially learn from, okay? So one of the ones that I think has been particularly successful is the Batten disease model. So this series of studies was run out of the University of Rochester in the United States. And they began in 2001 working with a family group to develop a registry to collect basically names of families and who has the disease, where are they? And then they began the natural history study in 2002 at a family group meeting, at a meeting that was organized by a group of families. This went on to develop a rating scale in 2005, which they validated. And then the development of a way to do this rating scale over telehealth, okay? And then this has now led to the implementation of clinical trials where various different treatments are being tested. But this kind of shows you the amount of time that this takes. And for people living with rare diseases that can sometimes be life-threatening, you know, that's a hard pill to swallow. So if you let's say you study a particular rare disease and you are at the beginning of your studies, which type of study would you prioritize?
Okay, so here is the poll. We will leave it open for another 15 seconds and then I will show the results. Okay, so here are the results.
Okay, so I think that this represents a good representation of everybody's thoughts on this, right? There really are pros and cons to everything, and you have to take into consideration lots of different factors. And for these reasons and others, what we decided to try and do, along with the Bow Foundation, is to try and do all of these at the same time, such that we were collecting data that could be used sooner while still starting the prospective study and getting the ball rolling. So the main model that we used in setting up the prospective part of this study was Wolfram disease, because I've been part of the Wolfram team nearly from the beginning of the development of this natural history study in 2010, way back when I was a fellow. Wolfram is, I don't want to go into the super specifics of the disease, but it's a disease that's made up of primarily diabetes mellitus and optic atrophy, but also can have many more symptoms, including diabetes insipidus and neurologic decline. And so, as you can see, the study has been very, very successful, especially since it's looking very much like Wolfram is much more rare than GNAO1. And for the first 3 years, they had both subjects and age max controls, which were usually siblings without the disease. And everybody came to St. Louis once a year in the summertime. And you can see the numbers of patients that have grown over the years. And they were able to attract families from all over the world, and they underwent a whole host of assessments to try and further characterize this disease. And so I looked at our experience with Wolfram, and I was the neurologic and movement disorder specialist on the team, one of a couple actually, and looked at what could I learn from their experience, and what do I need to take into account in designing what we're measuring and how we're moving forward. And the first one, which I've already alluded to, is that the phenotype of the disease, of the genetic disease, is not equal the phenotype for the clinically defined disease. So previously, prior to the gene, there was this clinically defined syndrome of the diabetes insipidus, mellitus, optic atrophy, and hearing loss. And what they found is that actually only 38% of the people who had the disease that was genetically defined, like a positive gene test, only 38% actually had that combination. And so not all the symptoms would manifest, and actually there were a lot more symptoms than was previously thought. So what we learned was that all of these systems were involved to some degree in Wolfram syndrome. It wasn't just diabetes and vision loss. And so we needed to take all of those things into account when trying to understand how the disease was progressing, and realize how all these other quote unquote smaller components of the disease were affecting these patients' lives. And at the time, we thought that the diabetes mellitus came on first, and then the optic atrophy, and that the neurologic disease didn't come about until much later. But one of the things that we learned from this study is actually there are very early effects on the brain that lead to very subtle neurologic changes that we would have never picked up on had we not been doing a prospective, very detailed oriented study. The third thing that I learned from looking at the data was that there's often a need for a disease-specific rating scale. And so what we did in Wolfram is we took the Batten's disease rating scale, and then we adjusted it to be more specific for Wolfram's. And then we validated this, and we adjusted it over time as we learned more and more. And then we were able to correlate this with the brain MRI changes that we saw. And we saw not the greatest correlation, but it's there. And so suggesting that this scale can potentially be used in lieu of serial MRIs as part of clinical trials. And so so I talked a little bit about our goals earlier, but what we really wanted to do in this natural history study was to define the clinical phenotype and basically establish feasibility for a longer term prospective study, begin to develop a rating scale, but then also what we heard from families is what they also really wanted was an initial set of best practice recommendations so that they could bring back to their local treating physicians and therapists. And so we set up a registry, and this is in coordination with the Bow Foundation. The PI on the principal investigator on this is actually Erica Axine at the University of Virginia, but I am part of the study team. And this is currently under review for publication. But there were 82 subjects that filled out the registry info, and this was parent or caregiver or self-entered data, which obviously has its pluses and minuses. And that the phenotypic spectrum seemed to be somewhat similar to what had been published previously, but possibly with a much wider severity, as I alluded to earlier. In that while almost all had hypotonia at birth, most developed either seizures or abnormal movements by the age of 10. And there's one patient that hasn't yet, but that patient or that subject is only 4. So for the prospective study, we wanted to have part of it be retrospective, where we just gathered medical records, and we thought that we could gather this from more people than we could do a prospective study on. And we aimed to have 20 for the prospective study, and we exceeded that amount. And what we really did is we had them move through different stations. So they would come into our clinical research center, and we would have them fill out questionnaires. We would get the medical records, and then there was a schedule, and they would go to see either me, where I would do dystonia and other movement rating scales. They would go to physical therapy, where they would get the GMFM. They would go to occupational therapy for the assessment with the Peabody, and then they saw one of the epileptologists, actually Dr. Axine. And so, and we hope that we could use these initial years to develop preliminary clinical guidelines, as well as the beginnings of a rating scale. So we were actually much more successful than we thought. We had to turn away families that wanted to participate because we just didn't have the capacity to do so. And so we scheduled 22 subjects, and then one I saw as my own patient. What we found is 100% hypotonia as infants, but there was a tremendous variability in the ability levels and movement disorders, kind of as you saw in that video. There seems to be a few different types of the movement disorder. There's a mixed dystonia chorea with underlying hypotonia. There's a mixed dystonia in chorea, which has a little bit of spasticity, which seems to be in the older kids. There's a kind of chorea only, which is the minority. And then there's this hypotonia with like a very profound hypokinesia, which seems to be more present in the very severe early infantile epileptic encephalopathy children. We immediately noticed that most of the kids seemed very happy and with infectious smiles and a very low kind of prevalence of irritability. If anything, there was some anxiety that is very common in movement disorders. And then we kind of uncovered some new symptoms that we hadn't been on our radar, including that a lot of the children have difficulties regulating their temperatures, either being too hot or too cold or sweating too much. And that a lot of the children have an aversion to bright sunlight, which I still don't completely understand, but was reported by many families. And so, like other rare disease studies, we found that the genotype doesn't always correlate to the phenotype. So I've broken this up into levels of disability using the a 1 through 5 scale, with 1 being the least amount affected, completely ambulatory, and 5 being needing to use a wheelchair all of the time for mobility. And you can see there was a very wide spectrum, although probably most of the children fell into a level where they weren't completely independently ambulatory, but they could weight bear, they could try and take steps, they could use a gait trainer, that type of thing. We had a big age range. Our youngest was 1.5 years old, and then we had a 23-year-old. And you can see, this is a busy slide, but what I'd like to highlight is that these are the levels of disability, again, 1 being the lowest, 5 being the worst. And the mutations don't correlate to the level of at least motor disability. So one patient who you can't even tell has a movement disorder by looking at him has the same mutation as somebody who has very limited mobility. And so these are some of the scales that I used to kind of try and quantify at least the movement portion and the quality of life portion. And so one of the things that we wanted to look at, so I'll go back just a second. And these are all validated weighting scales, but not for GNAO1. And they're all very kind of generic, non-specific. And so what I was really hoping to do with these first 2 years was to see, okay, what parts of these scales would work for GNAO1? What can I pull from them? And then what is really not going to work? And such that I can pull what's useful for a disease-specific rating scales and discard what is obviously not useful. And so what we found is that, again, this is broken up. Level 1 is ambulatory, and level 5, it has the worst amount of motor disability. We found that these various measures of dystonia and chorea did not necessarily correlate with the level of motor disability, meaning that, you know, somebody with who is very functional from a motor standpoint could have a lot of dystonia and a lot of chorea, and the opposite could be true in somebody who had very little movement. And we found that the level of disability actually correlated more with the hypotonia rather than the abnormal movements. So then we wanted to look at caregiver level of responsibility and burden, and basically quality of life measures. And we used primarily the CP Child for this. So, and we also looked at what was most important to the families. What were they most, what caused the most problems? And I'm just curious what you think was the parents rated as the thing that was most problematic or that concerned them the most.
Okay, so you have 15 seconds more to choose one of the options here, and then I will show the results. Okay, and here are the results.
Okay, so so that is actually correct. So even though the seizures and the abnormal movements are the things that lead to the hospitalization, what concerned most families the most was difficulties with communication. And this is in large part because a lot of times intellect does seem to be preserved, but the children have quite a bit of difficulty even with standard communication devices because of the abnormal movements. And so one of the things that I wanted to compare was how does the quality of life compare to, say, your run-of-the-mill cerebral palsy. And I thought that this might be different, but actually it wasn't. So the quality of life really kind of trended with the level of motor disability as it does with cerebral palsy. But interestingly enough, if you look at this graph right here, you know, as you're moving forward, the things that seem to decline, at least at first, the comfort and emotions did not decline nearly as much as you would expect with declining motor function, and kind of going along a little bit with what we had noticed in that the children all seem to be very happy and with a low level of like psychiatric comorbidities. And so we obviously in this year had to transition to virtual data collection. I'm just going to show you some video of how we did that.
So we're going to redo the same test that we did last year. Does she have all of her braces and everything off already?
Yep.
All right, well, let's go ahead and get her ready and we'll get started.
Okay, reach for Daddy's hand. Can you reach? What? Hey.
Like this. Yeah, you want to get your unicorn? Here, reach for unicorn.
Unicorn. Can you show me your unicorn? Can you reach forward? Reach forward, both hands.
Can you use both hands?
Good girl. Do you think she can reach across her body to give you a high five on either side?
Can you reach with this hand to give mommy a high five? Yay!
Now give me one with the other hand.
Give Daddy a high five.
With the other hand, that one. Boom.
Good girl. Start with one where she can touch. We'll do
Okay.
both.
Okay, can you see her then?
Perfect.
Hold back.
Perfect.
Hold up.
And then can you lift your hands up in the air?
Lift your hands up. She's gonna lift her hands up. Like this.
Everybody's doing it.
Yeah, like all the time at dinner. Yeah.
There you go.
Yeah.
Good job.
Yeah.
Yeah, I don't know.
I know. I'm like, what are you going to? Very good. Take a flat feet and just hold on. Make sure your feet are further apart.
There you
Okay, so you could have
So we're gonna
have a little bit of an idea of how we collected the data. I don't want to belabor this point, just to say that we found a similar breadth of motor disability throughout, and similarly, the exact mutation did not correlate with that. We're still in the processes of looking at the data and comparing, especially year 1 versus year 2. The only thing that we kind of pulled out thus far was that potentially the abnormal involuntary movement score, or the measurement of the chorea, was lower in year 2 than year 1. Now, we have one of the caveats to this is that this has not undergone a blinded assessment, so this could represent some sort of bias in the way that I was measuring or rating things in year 1 versus year 2. Nothing else has been pulled out yet as significant. So to kind of wrap up, you know, people always want to say, well, you know, have you found out what seems to work better than other things? For the epilepsy, there's really no medication that seems to work better than others. That there are a few things here or there that you can say, well, maybe the ketogenic diet, maybe this or that, but really it's not been consistent. And there's also a much wider spectrum of the epilepsy than we previously knew. And that could be reflective in that, and that some things work better for the EIEE, but maybe not later on in life. The movement disorder is usually pretty refractory to meds and changes over time. So what may work when the child is 3 may not work when they're 7. Especially since the dystonia seems to come on a little bit earlier, may respond to things like Sinemet or Artane early. but later may make the hyperkinetic disorder worse. The one exclusion to this is that DBS, or deep brain stimulation, does seem to be effective at reducing at least the hyperkinetic movements. So we now have 8 patients that have been implanted, and there are, I think, 2 others that are in this in the stages of, or planning to be implanted when I last talked to them. All of the subjects have had improvements in their hyperkinetic movements, and in some cases, it's been life-saving. However, it's been a little bit disappointing in that while some people have had success in improving dystonia, a lot haven't. Oh, and I lost my place, but I wanted to show you.
I don't get to play with him all.
Sorry.
And our other named Isaiah. He's so funny. This is my sir, Proton. He comes to doctor appointments and on vacations with us. And when we are out in public, he's a great wingman. I'm a student at the local community college. Right now, my career plan is to be a documentary filmmaker. I'm a huge NASCAR fan. At one race at the New Hampshire Motor Speedway, I met my favorite driver, Kevin Harvick. I decided to do deep brain stimulation, which has stopped my uncontrollable movements. Before the surgery, when I got excited, my body would get really wiggly. Now, my body is calm. DBS helped me be able to get a tattoo of the Boston Red Sox B on my arm. I really don't mind having a disability. I just wish I didn't have so many doctor's appointments and IVs, and that the world was totally wheelchair accessible, especially my friends' homes. I also hate when people talk to me like I'm a 3-year-old because I use a communication device and a wheelchair. The positive thing about having a disability is that I have an awesome team every day. I also like being part of the disability community.
Okay, so some broad conclusions. There does seem to be a different movement disorder phenotype versus an epilepsy, although there's a lot of overlap. We think that this disease is vastly underestimated, and that there are many, many more mild cases out there, and that we are now working to try and convince companies to put GNAO1 on some of the things like hypotonia panels and dystonia panels, as well as just developmental delay panels, so that hopefully we'll get a better sense of exactly what the prevalence is, and that we really need flexible data collection. Part of the reasons why the motor scales were not that great at helping us understand is that they inherently change throughout the day. And so getting a snapshot was really not helpful. And so we're working on developing ways that we can better quantify the abnormal movements throughout the day. And we really need better objective measurements of communication and cognitive functioning, both to help the families understand how to better educate their children, but also as another way to track the disease progression. And so we're currently working on expanding our study team and potentially opening up a site in Europe. And I would love to hear from anybody else who would be interested in working with us, and developing a rating scale while the basic scientists try and figure out a little bit more about possible cures. And one of my potential interests that we now have a working group, an international working group, to help try and figure out is the role of DBS, and should we be implanting these children younger before they end up in the ICU, and really how young is too young, and pushing the boundaries on that. So in conclusion, some general lessons. The biggest challenges in doing this type of research is funding, and everybody knows that. Publishing can also be difficult because of finding a journal that fits and is interested in publishing something on a rare disease, although this is getting a little bit easier. the statistics can be tricky. And so identifying a statistician early is probably helpful. And identifying collaborators, although the Bow Foundation has been great at helping us do that. And then some surprises. Genetic testing has really changed how we look at things and how we look at disease. The phenotypic variability is much higher the more and more we test, and that it's very gratifying to work with these families. So if I know I'm probably at the end of my time, but if anybody has questions, I'm happy to answer them now or via email.
Okay, thank you, Amy, for this very interesting presentation. So we have already 2 questions. One is, can autonomic instability be a life-threatening condition in GNAO1 disease?
So I'm not, to answer your question, I'm not sure. When I've seen it at its worst, it's usually in the setting of other things that are going on and other reasons why the child is in the ICU. I will say that the reason why I'm convinced that the autonomic instability is separate and not just related to the kid having lots and lots of movements is that, and I've now seen it twice, where I've had the child, for whatever reason, is intubated, sedated, and paralyzed, and we still see like these episodes of tachycardia, fever where, you know, there's no infectious source, and sweating. And then, you know, the fact that we're seeing these kind of subtle changes that families report, where kids just run fevers for no reason, that can be identified, or, you know, they're all of a sudden they get too cold, or, you know, that their limbs are really cold and develop, you know, skin changes. I think it warrants more investigation, but it can be severe, but usually it's in the setting of the child is very, very sick, you know, and I've not heard of it directly causing death, but usually the factors in those kids who die is multifactorial anyway.
Mm-hmm. Thank you. How have you addressed the phenotypic variability when developing a sensitive clinical endpoint?
Yes. So this is part of the problem is that a lot of these scales have a ceiling or a floor effect, meaning that, you know, for example, in dystonia for DBS, a lot of our kids will have like maxed out score on the typical dystonia rating scales, and they may improve, but their score might not change. And that's in part because a lot of these scales were developed for adults first. And so one of the things that we like about the GMFM, the gross motor function measure, is that we don't have that ceiling and floor effect. It's, you know, because it's meant to measure from birth. And so even the littlest, you know, ability of head control will give you some points, you know. And so that's, I think we're definitely probably going to continue to use that. And I think that as I'm developing the ratings, the portion of the rating scale for the movement disorder, I'm going to have to essentially come up with our own, where especially the ceiling effect is much higher, such that we can detect changes or more subtle changes. For the epilepsy, coming up with the rating scales is more challenging, and especially since the epilepsy seems to really, really change over time, or be very different in very different kids. And so Dr. Axine is working more on that part of it.
All right. Okay. Have these children also ataxia?
Not in the absence of abnormal movements. So I think any problems with balance are more due to the dystonia. Now it's a little bit difficult to tease out, I will say that. And so, but especially those kids that have less abnormal movements, and less hypotonia do not seem to be ataxic at all.
Okay, thank you. So if there are no more questions, so many participants are already saying thank you for the great talk. So very many thanks, Amy. Please stay tuned on our channel. We are having the next webinar on the 23rd of February, and we're continuing with a very interesting webinar topic. So you can see our program on our website, and stay safe. Thank you very much to everybody, and bye-bye.